Good afternoon, ladies and gentlemen. It's my honor and pleasure to welcome you all to the 13th Professor B.K.Aikat Memorial Oration to honor a great visionary, an academician, a true guru, a man who has left a colossal legacy behind him, the founder of the Department of Pathology, PGI Chandigarh, Professor B.K.Aikat. For this oration, we have today Dr. Murli Verma, an alumni of the Department of Pathology, PGI, who is presently a consultant in the University Hospital of Wales, Cardiff, in the UK. And ladies and gentlemen, we also have amongst us many students of Professor B.K. Aikat, who have come here to pay their homage to this great soul. Amongst them, there are lots of them here, but there's a little request because Dr. Khan has written a book recently at this age, and he has dedicated that book to in the memory of Dr. B.K. Aikat. So to begin with, I humbly call upon our dynamic director, Professor Vivek Lal, to welcome everyone and introduce the great stalwart and icon, Professor B.K. Aikat, a name which is engraved on every brick of the Department of Pathology of PGI Chandigarh. Sir, please.
I actually am deeply privileged to be introducing a giant, and easily is one of the 5 founding fathers of this institute. If you understand what this institute stands for, so easily one of the 5 founding fathers. So it's and first of all, I welcome all of you. You know, I'm seeing pathology legends on the front rows, and each one of them is a class apart. I often say that the Department of Pathology is a Milky Way in PGI. If you understand the meaning of the word Milky Way, and I'll have to use these words again and again. You know, the Department of Pathology is a Milky Way. I met a legend of pathology called Professor Vinay Kumar, editor-in-chief of Robbins. So he had come here because one of his relatives was admitted under me in neurology. Vinay and I come from the same medical college, Amritsar Medical College. And on a personal note, I had a very strange grudge against him. In my second professional, my pathology viva went on and on for 3 hours. My examiners were Professor Sood from, I think, UCMS Delhi, and the other one was, I don't know where he from. And it started at 8 o'clock and it stopped at 11 o'clock. Non-stop 3 hours ragging by a pathologist. And I answered every question under the sun. Mind you, I was in Amritsar Medical College, which was worse than a veterinary college at that time. I don't know whether it's any better now, but I answered every question. Then at 11 o'clock, Professor Sood said, I want to give him distinction. This boy has been exceptional. And the internal said, no, he does not know as much as Vinay Kumar. That was the first time I came to know that Vinay is from the same college as I am, and I cried there, not because of being deprived of distinction, because I said, here you are comparing me with the author of the book which I have read to appear in this exam. There cannot be a bigger honor for me. And I conveyed this to Professor Vinay Kumar when he said, Vivek, the Department of Pathology, he had visited your department that day and he had come on his way back to meet me. He said, Vivek, they have the best pathology department in the whole world. And this is when he was heading Johns Hopkins. He was heading clinical pathology in Johns Hopkins. He made this colossal statement. So the founding father behind this great department, you said his name is imprinted on every brick. Not only name, his cigars are also imprinted on every brick, if you know what he meant. And he was a class apart. Professor Aikat was born in Patna. He went on to do his MD in tropical medicine. He had numerous degrees to his credit, but everything pales into insignificance when we say he started the Department of Pathology in PGI MER Chandigarh. To give you an example of the colossal, problem with we all is, now that I'm the director, I'm supposed to highlight the good things and hide the bad things. So that's my job. You should know what are the good things about your department. M.J. Anderson, which considers itself the best, one of the best cancer institutes in the world, gives a report of CEA. If you get your sample today, it will come after 2 weeks. Your department gives it in 48 hours. There are so many other tests which MJ Anderson takes weeks to report, which you do within 48 hours. One. Number two, of course, you are known for the incredible impact that your reporting has on the future of cancer patients, on the future of all those who come to you for second opinions. It's human to, err. But I think in the Department of Pathology in the last 35 years, that is a very, very low percentage. I overheard Professor Murli talking about two types of mistakes which we commit. This in the Department of Pathology. You are not from Wales, so you are an ex-alumnus. Okay, that's good. But you're basically now a Firang, which is fine. So you can never understand. You should understand, or probably you'll remember that this department is unique in every way. It's unique in every way. Their day begins at 7 in the evening. It goes on till 1 o'clock at night. Because the patient who's got to be operated the next day is waiting for the report. It does not happen anywhere else. And I can tell you, I am one person who calls a spade a spade. I was once called by someone from the highest office of this land, and I'm sharing it with you, to pick up a department which you consider the best. Without blinking or batting an eyelid, I said the Department of Pathology. And this happened some time back, and it was for a good cause. The Department of Pathology is unique in every way. As I said, it's a Milky Way. I bow in front of giants like Professor Aikat. I see other giants, Professor Rajwanshi, the one sitting next to him, Professor Subhash Verma, and so many others, Kusum, ma'am, I use the word ma'ams, don't mind it, right? Taken together, they have created a river of knowledge and a spirit of commitment like no other. When we have a oration, it's important that we look beyond the CV of the individual. CVs are just plastic papers. Look beyond the CV of the individual. There might be a author who's got 1,000 publications but is good for nuts. There's no dearth of them, I'm telling you. But there is someone who may just have 20 but makes a huge impact. So huge that he continues to stay through his students, through his legacy, which will never ever fade away. The Department of Pathology is one such legacy of his. His students, I was just seeing those photographs, I recognized almost all the professors when they were, young, right? And it's just one man's legacy. Just one man's legacy. Professor Aikat and his cigars. Let me complete the sentence. He got energy from his cigars. There are some people who get it from cigars. Winston Churchill got it from wine, and so on and so forth. But then that was Professor Aikat. And then that was PGI Chandigarh when it wrote a 3-volume textbook of hematology. All the authors from India, all from PGI. There cannot be a better and a more powerful statement of the legacy of such giants. I take a bow and I welcome Professor Murli. Thank you so much for coming. Welcome means, I'm welcoming, you keep sitting, sir. Right? You could have a formal welcome. And I only hope that the students of today who are doing pathology understand just how lucky you are to be in a department which Vinay Kumar calls the best in the world. Thank you so much once again. Welcome to the show.
Thank you so much, sir, for encouraging us in such a beautiful manner. I now have the pleasure to call upon Dr. S. Radhika, head of the Department of Cytology and Gynec Pathology and the senior most professor of the Department of Pathology, to introduce our eminent orator, Dr. Murli Verma.
Thank you very much, Dr. Nandita, and a very good afternoon to all of you. Honorable Director of PGI, Dean, former deans, former directors, respected teachers, of mine, faculty, staff members, students, residents. A very warm welcome to all of you, and it gives me great pleasure to introduce my very good friend of many decades, I would say, Dr. Murli Verma, today's orator. And just a throwback, these are some pictures from the archives I just pulled out. The first one on the right is, Professor Aikat with Zakir, the Vice President of India, Zakir Hussain, and the Zakir Hall is named after him. Then the visit of SP there, and you can see Professor Tutani and Professor Aikat. And then, of course, the electron microscope. It was the first installation anywhere in the country. And of course, here we have the President of India, Honorable President of India, being welcomed by Professor Aikat there, Radhakrishnan there. This is Professor Aikat with his all his students. And of course, there are many sitting in the front row, Segal ma'am, CKB ma'am, all of them being the first generation of students, and then we, their students, and the legacy, like Dr. Vivek Lal said, continues. So coming to the orator, which is the task given to me. So these are Dr. Murli Verma is currently a consultant histopathologist in the University Hospital of Wales at Cardiff, UK. But he started his journey, actually, his pathology journey in PGI, Chandigarh. He was here from 84 to 87, 3 years as a junior resident, followed by senior residency. From there, he had a brief stint at Hinduja Hospital, followed by Royal Victoria, Belfast, and then he did his residency and fellowship at the Henry Ford Hospital, Detroit, and then, of course, relocated to the UK, where he is currently serving as a consultant histopathologist. And yes, ladies and gentlemen, he is one of the 3 Kataria Gold Medal winners from the Department of Pathology. He got the Kataria Gold Medal in the year 86-87, and he has numerous positions, so it will take me a lot of time if I have to go through, but mainly he's an internationally renowned surgical pathologist, a urological pathologist, so he's in all these committees of uropathology, and involved in the WHO Blue Book. He's authored 2 chapters, and he, of course, he's there in the Royal College of Pathology Dataset Committee as an expert, and also on the ICCR reporting data sets. I'm keeping it short in the interest of time. He has numerous publications, conducted so many courses, lectures, and this morning we had a great talk by Murli in the department. So here's the Murli as a resident, as a junior resident. And I think you can spot him there on the Chiron block steps of Chiron there. I put an orange arrow, but I don't think it is required. This was the department in 1985 when Professor Datta left for a brief stint in Libya. And Murli was an all-rounder, which is why he got the Kataria Gold Medal. And a wonderful friend, always jovial, happy, happy-go-lucky types. And that was in one of the picnics there. And I think you can, besides him, you can spot a few more former faculty, maybe. So I leave it to you. And then it's the post, when the only time we defeated internal medicine in cricket, we had a post-match party hosted by Dr. Bush, and we really enjoyed that. And that's our coffee club, where we used to spend a lot of time. Of course, very scared of all our teachers at that time. And this is when we won a lot of medals in the Spring Fest, way back. And that's, of course, me. We 3 had formed a team. And of course, we had just won the dumb charades. 3 dumb people winning the dumb charades. But there he is. So this is Murli. And over to you, Dr. Murli.
Thank you, ma'am. It's my greatest pleasure now to call upon Dr. Murli Verma to deliver this prestigious Professor B.K.Aikat oration. Sir, please.
Thank you. Thank you, Radhika, for the very kind introduction. What can I say? It's a great honor. It's always a great honor to be invited to give an oration in such a prestigious place.
but it's an even greater honor, when you are invited to give a presentation where you actually learned pathology, where you started your journey. And to be honest, it's a journey that is still going on. I'm still learning pathology, I can assure you that. So I'm very grateful for this invite to do this. Isaac Newton's quote, that if I've seen further than others, it is by standing on the shoulders of giants. And I can tell you, there is no dearth of giants in this department. Now, if I put all the names of all the giants, there would be no time for this lecture, there would be no place on this slide. So I've put in four who were major influences for me. There are many others in the front row here, right, who it's a delight to see. But I would say this, if you put Newton's comment in an Indian context, think about Janmashtami, on the shoulders of others. But there is another message in this. Yes, you learn from giants, but we learn from each other. We all learn from, so whenever we come up with great ideas, it's never our own ideas. We have always developed those ideas from what we have seen. And I can tell you today, I'm going to share with you some of the views which may seem a bit radical, because I'll be dealing with some of the issues in histopathology practice, challenging some of these issues, proposing a radically different way of histopathology reporting. I would love to say these are my ideas. No, this very hall, sitting through the various CPCs. So we had the interaction between, the interplay between pathology and clinical medicine, which you don't get, I think, in any other institution. So we were extremely fortunate to see how pathology is used by clinicians, and that pathology is not just data to be filed away. So let's talk about the standard histopathology focus. So standard focus is on accuracy, getting the diagnosis right, precision, getting the cutoffs exactly right, reproducibility, standardization, and completeness. Now, all of these are important, but I will try to argue that these are not the most important things in histopathology and suggest a different way of looking at things. So I'll go through some issues with current histopathology reporting practice and suggest another approach. Now, some of this will be, as I said, radical, and you may not agree with all of this, and that is perfectly fine. All I ask you to do is to seriously consider what I'm saying. And if you then feel that you've got good counter-arguments against it, then that's fine. You may adopt some of what I say, or you may adopt none of what I say, but consider it very seriously. And then I will end by showing you that this approach is not theoretical. It has impact for patient care, that if we adopt this different way of looking at histopathology, we could actually make things better for patients and easier for ourselves. So let's start with completeness. Okay, histopathologists, I think you'll have to admit it, okay, we have certain personality traits. Perfectionism, OCD, paranoia, conformism, those are all typical traits that I think many of us in this room have. And they're necessary traits, they're not bad traits. Because you need to be in histopathology, you can't afford to make mistakes. It's often when you make your diagnosis of cancer or not, it's a life and death issue. So you have to be. But sometimes these same traits can cause problems for what we do, in what we are trying to do and what we actually do. So let's start with completeness. So we like to have a complete histopathology report. But there are problems with that. The first is information overload. Here is a typical histopathology report from Wales. It may not reflect what's here in PGI, right? You might be doing it very differently. But look at this. This patient's got prostate cancer on one side of the prostate. Fortunately, the other side was all negative. There are 11 measurements in there, 9 in the text and 2 in the conclusion. And in addition to that, there's data such as focus suspicious for high-grade PIN, absolutely no clinical significance in this situation. But pathologists are scared of missing anything, so we put everything in. Here's another one here, nephrectomy specimen. So it has a lot of measurements. Kidney with fat measuring 175 by whatever. Tell me, who wants to know how much fat has been removed, unless the patient wants to know how much weight loss, in which case use a weighing scale rather than trying to measure the specimen. But the point I'm trying to make here, as pathologists, we often fill our data with a lot of information that nobody wants and nobody needs. And then we complain that these clinicians don't read our reports. Obviously, they are busy people. They have got other things to do. So if it's like this. This is a stamp album. Beautiful stamps. But you can't post any letters with these stamps. So a pathology report should not be filled up with beautiful data items that you can't actually use, right? So a pathology report is a practical document for treating patients. Never forget that. So my advice to trainees is when you put your data in there, always think, why am I writing any of this? Does it have it, and how does it affect? So always keep thinking. I think this is where I think, PGI has taught me many things. But the most important things that I learned from PGI, one was the clinical path interaction, while the other was simply to think for myself. So don't accept things just because somebody says, don't accept things just because Murli Verma said so. Why does he say so? Consider the points and then make up your mind. So what I'm talking about is maybe we should collect less data, collect it better, and report it accurately. So what is the problem with putting all that data in there? If you put a lot of extra data which the clinicians can ignore, it comes with risks. It's a waste of time. Your time, the secretary's time, everybody's time put in. Don't forget, all that data you write, you've got to type and check. There's one difference between humans and machines. So if I want to do a lot of PSA tests, what do I have to do? Buy some more machines, run those machines 24 hours a day. You can put all your blood in there. The machine won't make a mistake. The machine doesn't get tired. The machine will give you the results. But we are not machines. So we have two constraints. Most of us want to go home at some stage. So the idea of sitting all night reporting stuff is not attractive. But even those of us who are workaholics and are willing to spend till the middle of the night, we have a limit in concentration span. So if we do a lot of unnecessary work, we will make errors. As human beings, it is inevitable that the amount that you can concentrate. So you need to focus your time and your concentration on data that really matters for patient care, not data for data's sake. You put a lot of extra information, there is a real risk that the clinician misses. And I'll tell you a story. So this was in Wales. It was a breast-wide local excision. The pathologist did a perfect job. He wrote the measurements from every single margin. There was measurement of the specimens, measurement, every single margin. And one of those measurements was 0. The clinician missed it. He didn't clearly state that the margin was positive. Patient came back with a recurrence. There was a lawsuit from that. The pathologist got into trouble not because he was lazy, but because he did too much and did not communicate that properly to the clinician. So that is a classic example where doing too much can also be dangerous. And then the more you write, the more you got to check. So this same report, you had so many numbers in there that the pathologist missed that on the text of the report, the Gleason score is 3 + 4. In the bottom, it is 3 + 3. So clearly one of them is wrong, right? But that happens. Now, the part of the reason the pathologist missed that was because there were so many numbers to check. The clinicians cannot use multiple dimensions. They can only use the maximum dimension. There is no mechanism in their guidelines to use these multiple dimensions. So when you give them all this data, they can't use the data, but you make mistakes. So what am I talking about? What is a different way of looking at histopathology where you focus on clinical utility of the data item and actually communication? And I'll talk a bit more about that. So this is where I talk about, just like you have personalized medicine, we need personalized histopathology reporting. What we do with histopathology reporting is every single case, I report exactly the same data. Clinicians wouldn't dream of asking the same question to every patient or recording the same information from every patient who comes to the door. They ask a question, the next question would be based on the answer. The examination that they do for every patient would be different. But pathologists, we examine every specimen in exactly the same way. So this is a paper that I had written, a review with Anita Borges. At this stage, I think I would like to pay my respects to Dr. Borges. So Dr. Borges was probably the ultimate surgical pathologist. She was the surgeon's pathologist, very much into putting this in a clinical context. She was the daughter of a surgeon, and she was, as I said, a surgeon's pathologist. There are also, what I'm trying to do here, I don't have time in 40 minutes to go through all the details of this, but I'm hoping to sufficiently stimulate your curiosity that you will go and read these various articles that have been written. So we had written these multiple articles, symposiums on the same topic, and then we did a whole symposium and a two-day webinar on the clinical utility of pathology data items. So I would recommend that because you will, there the arguments are made much better than I can do in a short lecture. So let's give you a taste of this. So what are we looking at? Clinical utility of data items, not generally, but in that particular patient. And when I talk about communication, I'm talking about communicating the message. Now, when we think about specimens, what do we think of? Is this a biopsy or is this a resection? Is it a small specimen or is it a large specimen? That is a typical pathology attitude, pathologist's way of looking at specimens. That is not, the way we need to be is more personalized. We need to think less about data. We need to think less about specimens and a lot more about the patients. So we are doctors, right? And it is all about patient care, and you are very much involved in patient care. So a patient-centric way of looking at these specimens is not as a small specimen, as a biopsy or a resection, but is this a diagnostic specimen, a prognostic specimen, or a therapeutic specimen? Let me explain. Now, if I take an example of a thyroid needle biopsy is largely a diagnostic specimen. They want, is this cancer or is this not cancer? They don't need any prognostic information like the size of the tumor, etc., in a biopsy. On the other hand, when they do a lobectomy, many of the times the diagnosis has already been made, right? It may be, so lobectomy may be diagnostic, but may be diagnostic and prognostic. But then you have specimens like a total thyroidectomy for Graves' disease. The diagnosis of Graves' disease is a clinical diagnosis based on serology. These patients undergo surgery only when they have failed medical treatment. You're never going to be able to see the typical pathological features of Graves' disease in these specimens because they've been treated. And the clinician doesn't want to know. He knows that the patient has Graves' disease. He's not waiting for you to tell him that. But yet, look at how many blocks we take. I'm not sure how many you take. I hope it is fewer. But in the UK, the recommendation is 5 blocks, 2 from each lobe and 1 from the isthmus. In Australia, it is 7 blocks for something that really is not necessary. So that's a waste. There are several specimens where we take a lot of blocks, where the clinician actually doesn't need anything from us. They have taken this out as part of a therapeutic procedure. A completion thyroidectomy, thyroidectomy for Graves, prolapse uterus, tubectomy, vasectomy, breast reduction. I could go on. And yet, pathologists can spend a lot of time with these specimens. And sometimes, when we do that, we not only waste resources, we actually harm patients. So which seems a weird thing to do as pathologists, not to spend time harming people. So let me show you this one. This is a classic example, TURP specimens. According to the UK guidelines, if you get 25 grams of chippings, it will be 9 blocks. If you get 70 grams, 19 blocks. And with these days, with large prostates and HOLEPs, it is not unusual to get 19 or 20 blocks because you get these they take out a lot of chippings and we take a lot of blocks. Let's step back and think about it clinically. Now, what are we looking at here? We are looking at a patient who presented with retention. They tried to treat the patient medically for retention. They failed medical treatment, and because they failed medical treatment, they did the resection. Okay, so that's the clinical side. From the pathology side, what are we trying to do? Are we trying to find the cause of the retention? If so, the cause of the retention, if it is BPH, but if cancer is the cause of the retention, it has to be a pretty large cancer to cause retention. And you need only 2 or 3 blocks to find that large cancer. So when we do extensive sampling, we are not trying to find the cause of it is to find incidental prostate cancer. So this is like, and this is just one example. There are several papers. So this paper recommended submission of 10 blocks because that would detect 96% of cancers in the specimen. But do we want to detect 96% of cancers in the specimen? Or should we be detecting 96% of cancers? If we do that, what are we doing? We are screening. So that is cancer screening. And have we informed the patient that we are screening? Have we counseled them? If you want to do a PSA test, you have to counsel the patient before doing a PSA test. But when the pathologist is screening the patient, so you have this strange situation where the patient was offered PSA screening and said, no, thank you. The same patient then undergoes a TURP and gets screened for prostate cancer without asking him. So we had argued against this strongly, that there are issues here that need to be, and it is a provocative title, Cancer Overdiagnosis Pathologists in the Dock. By putting too much, trying to find these incidental harmless cancers, we are doing more harm than good. Let's think of it scientifically now. Okay, so I told you clinically, it doesn't make sense. It doesn't make scientific sense what we are doing. How much are we really examining? Here are some calculations for you. If I've got a 25-gram TURP and I all embed it, it will require about 13 blocks. If I put 3 blocks, if I all embed it, I'm examining one 5-micron section for every 3 to 4 millimeters, which means I've examined 0.13%. So when you all embed your tumor or all embed the specimen, you have examined about 0.13. That's a very, very, very tiny fraction of the specimen. So when you put 3 blocks and 13 blocks, the difference, you have an additional 10 blocks to examine an additional 0.1% of the specimen. Is that cost effective? Is that a good use of pathology time, or should we use the pathologist time for more clinically useful purposes? I'm glad to say I have been able to convince some of the big names in geopathology. So as you can see, we've got Mehul Amin, we've got Jonathan Epstein, we've got Theo van der Kolk. There's some very big names in that list. So I think we got consensus that we are oversampling and that we need to reduce the amount of sampling. All the experts agree. What we haven't got a consensus is how few. We need fewer blocks. Some of us feel we need very few blocks. Others feel we need a bit more. So it is still work in progress. But what I'm trying to say is we need to think about this. And this is a very serious issue, specimen oversampling. I like to say, sometimes pathologists are like ancient Egyptians. 0.2% of the submitted tissue is examined microscopically. Rest of the tissue, what happens to it? It goes in wax and stays in our files in wax, never to be seen again. So both of us, we are just into embalming. The Egyptians used to take great care in preserving the tissues and putting it in a pyramid and hiding it there in the hope that nobody will see it again. We take great care putting it into wax and putting it into the files, hoping that, we're expecting that nobody will see it ever again. So it is not about putting things in wax. And then we have guidelines. I don't think guidelines make life any easier or any more scientific. Guidelines recommend 1 block per centimeter. I'm surprised that, I'm sure people have thought about it, but nobody has questioned, okay, you're asking me to submit 1 block, but what is a block? I don't know, nobody knows. If I put that in 2 cassettes, all of us in this room will agree that that is 2 blocks. But if I take those same 2 pieces and put it in 1 cassette, is that 1 block or is that 2 blocks? Take your pick, nobody knows, okay? So what I'm trying to say is that even the guidelines are ambiguous. So the key here is not how much tissue you sample, it's what tissue you sample. Targeted sampling, submit. Now, I'll give you an example. Here's the renal cell carcinoma. You can see those yellow and red areas. You can take 100 blocks from that area, you will get the diagnosis wrong if you do not notice that area which looks different, and that is sarcomatoid change. So you can take 100 blocks from that area and report that as a low-grade renal cell carcinoma, and the patient will come back with metastasis because you did not sample the sarcomatoid area. So what the key is to carefully, and what do? We do the opposite. The microscopy is reported by expert pathologists with years of experience. The macroscopy is done by junior pathologists with trainees with very little experience. And that is weird, because if you miss that, it doesn't matter who's reporting it. So as I said, quality trumps. So maybe when you get something that is grossly homogeneous, everything looks the same, then it's going to be a chance finding what you find. Maybe fewer blocks should do. At least we need to start thinking about it. We need to talk about it. And then we have this one size fits all. And I have to say this very frankly. It's not that I would say you should never ever do everything that Murli Verma does. Because what is right in the UK may not be right in Chandigarh. You have to personalize so what is right, you have to personalize it for the individual case and for institutional requirements. So let me give you an example. Lymphovascular invasion and testicular non-seminomatous tumor. In stage 1 disease, it is critical because if you report vascular invasion, the patient is going to get PEP chemotherapy. So it's critical. But the same data item in a patient with lymph node mets, stage 2 disease, is irrelevant because that patient is going to get PEP based on the lymph node mets. But pathologists take the same amount of care to report it. Same way in prostate biopsies, you report the extent of tumor that can be important in a patient who's for active surveillance. But if you've got a patient, like in a digital biopsy or targeted biopsy, where clinically he's got locally advanced cancer, what are you reporting the length of the tumor for? Nobody cares. They know that he's got a large amount of tumor in the prostate, and the maximum you can get in a needle biopsy is 20 millimeter, so that's the size of your core. So these are, you have to put more energy focusing on ones where it matters. And then, in the UK, some centers do focal therapy for prostate cancer. They need that, urologist would need more data from the pathologist. But for me in Cardiff, to provide detailed data that is required for focal therapy when my urologists do not offer focal therapy is madness. If the patient goes to London in the private sector, because focal therapy is largely in the private sector, that pathologist is going to review my slides. In different healthcare systems, here's a classic example for you. The weight of the uterus. I'm not sure how many of you record the weight of the uterus. Your clinicians couldn't care less, okay? I can't think of any gynecologist who cares about the weight of the uterus. But if you are in the US and you don't report the weight of the uterus, you are guaranteed to get a phone call. And that's because the US surgeon's reimbursement depends on the weight of the uterus. There's a 250-gram cutoff. So they use it as a surrogate for the complexity of the surgery, right? So in the US, the weight of the uterus is critical. In UK and in India, it is not. Because but we have to think. So when you get American pathologists saying that you have to report the weight of the uterus, just think, why are they asking that? And then communication. Now, when we talk about communication of pathology reports, we generally talk about formatting, the synoptic report, how it looks. That is all cosmetic. That is not what I'm talking about. I'm talking about communicating the message and the interpretation in complex cases. So why do we need it? Because there is a communication gap between us and the clinicians. It's not a gap, it's a Grand Canyon. And that's because if you take radiology and pathology, surgeons view radiology images. Surgeons wouldn't dream of looking at radiology reports without the images. But when it comes to pathology, they don't look at pathology images, right? So there is a communication gap. So they totally depend on what we tell them. So our reports have to bridge this communication gap. So having said all this, this is all theory, right? I tried to explain to you why we need to think differently and maybe have a different mental approach to histopathology reporting. Now let me show you something in practice, how this can actually make patients' care better. So tumor grading, and I'm going to use bladder cancer grading. I think if I'm right, in the UK, like in the US, you use the binary grading system, low grade, high grade. I hope that by the time you step out of this door, you will be reconsidering that. Let's see. So I'm going to use bladder grading as an example, but these principles are just as applicable to grading of any tumors. So what's our focus in grading? To get the accurate grade, the precise grade, and reproducible grade. I'm going to argue that none of these are really important. So this is a paper that we published that in tumor grading, accuracy is overrated, precision is not necessary, reproducibility is generally not critical. And what we argued here, and again, you got some pretty good, big names there. So it's not just Murli Verma, spouting his favorite bit. But we argue that communication is the key. So let's start with accuracy. Think about what we're doing. When you got grading, grade is a biological continuum. So if you're taking progression risk, metastatic risk, risk of death, the risk progressively increases. So at what risk of progression or of metastasis or of death would you call something high grade as opposed to low grade? Entirely arbitrary. So is it 1% risk of progression or 3% risk or 5% risk? There is no answer. So what I'm trying to say is that this cutoff between low grade and high grade is an entirely arbitrary cutoff. Because what you're trying to do is this very difficult and very delicate balance between overdiagnosis and overtreatment and undertreatment. Ideally, you want zero overtreatment and zero undertreatment. Unfortunately, you're living in the real world. In the real world, it's practically impossible. So you are trying to balance the two, trying to get the minimum amount of undertreatment we can get away with and the minimum amount of overtreatment. And it also depends on what the treatment options are, obviously. So you got this line between low grade and high grade. If I move the line to the right, you're increasing the risk of undertreatment. If you move it to the left, you're decreasing. So depending on whether you are more worried about undertreatment or you're more worried about overtreatment, that line that you draw between low grade and high grade will change. Which is why if you're an American pathologist, maybe an American urologist, more worried about undertreatment. And there's also, to say very softly, there's a financial incentive for overtreatment. You would prefer the line in one place. If you are in the UK, the urologist may prefer the line in a different place. So neither of them are wrong. It's just, but the problem is not the urologist. The problem is the pathologist. The pathology report says high-grade urothelial carcinoma. Now that could be a tumor that is at the low end of high grade, which is basically a case that on Monday I would call it high grade, on Tuesday I would call it low grade. If you show it to two experts, one expert will report it as low grade, the other expert will report it as high grade. That patient's treatment should not depend on whether I reported it on Monday or Tuesday, right? On the other hand, so this patient could potentially be managed as low grade. So this is no different from a bad low grade tumor. On the other hand, this high grade urothelial carcinoma could be at the bad end of high grade, where the patient cannot be recommended any treatment other than as high grade. The patient might choose to be treated as low grade. That's his prerogative. But the urologist cannot recommend low grade therapy. But the difficulty we have is the report doesn't indicate it. And as I said before, the urologist doesn't look at the pathology images. So how is the urologist supposed to know whether this is at the low end where the patient will be given options, or is it at the high end where the patient has to be treated as high grade? If you think that pathologists are strange, no, the clinicians are the same. So you got these cutoffs for hypertension. Where did these 130 and 140 come from? Right? It is just pulled from the air. And you need proof that it's pulled from the air? Because as I say, if you're mildly hypertensive in New York, there is one way of curing your hypertension permanently without any intervention. Just take a flight to London. When you land in London, your hypertension is gone permanently. And that's because the cutoffs. If you got a blood pressure of 135, you are hypertensive in US, because for the American cardiologist, the cutoff is 130. But if you land in London, for the European cardiologist, the cutoff is 140. So 135 is hypertensive in New York, but not in London. So what I'm trying to say, these cutoffs in continuums is always arbitrary. So this is not something that's special to pathologists. And what about getting it exactly right? Do we really need, as I said, the ones that are borderline, there's no difference. And so it would be reasonable to treat these patients as either low grade or high grade. Again, if I come back to hypertension, if you got somebody with 119, they should not be offered treatment. If it is somebody who's got 159, they probably need treatment. But those borderline ones, it's options. You consider, you explain to the patient, you take the other risk factors, and then it's the same here. What about reproducibility? Is it critical? Yes. To distinguish the low end of high grade and the bad end of high grade is critical. My second year trainee can do that with no problems whatsoever. But the other one, the one we worry about, the one we argue about, really doesn't matter. Reproducibility studies have no scientific basis. You tell me what kappa value you want, I'll get it for you. Let me choose the participants, let me choose the cases. You want to say it's highly reproducible? I take 100 straightforward cases with 100 pathologists who work together. If you want low kappa value, I take 100 borderline cases and pathologists who have never worked together. So these now reproducibility study, we use them to justify whatever arguments we want, but it's not scientific. Okay, I'm going to rush through a little bit. So is it critical to reproducibly distinguish? Probably not. Okay, so I'm going the wrong way. So this is what we published. This is actually no longer in press. It has been published. It's basically saying that for urothelial carcinoma grading, it has to be more categories are better. If you want a more complete picture and not just Murli Varma's biased opinions, you can get a more complete picture with this head-to-head debate where you get the biased opinions of 3 experts who have 3 different views. So Eva Comparat, who was then in Paris, Theo van der Kwast in Toronto, had different views, and each of us independently made our arguments. So I strongly recommend reading this paper because it gives you different aspects independently, and I think we had this table which clearly shows the various advantages and disadvantages of each. Obviously, today I'm going to stand here and give you just a brief spiel on my take on it. So go to the paper to see what Eva argues and what Theo argues. That's relevant. But let me just end with this. So the main argument of the two-tier system, that it's easier for the pathologists and easier for the clinicians to deal with a low-grade, high-grade, rather than a multi-tier system. I don't think so. I think that simply is not true. More tiers easier for pathologists? I think so. The more tiers you have, actually the stress on you becomes less. Because if you have more tiers, then distinction between adjacent tiers become less important. And as I have there on that table, we know that from experience. We had a 1-tier system called Gleason 7. What did we do? We split it and made it a 2-tier system, 3+4 and 4+3. It became absolutely critical to distinguish between 3+4 or between 3+3 and 3+4 and between 3+4 and 4+3, management differences. But the moment we started reporting percentage 4, life became easy, because whether I report it as 3+3 or less than 5% pattern 4, or I report it as 3+4, 50% pattern 4, or 4+3, 60% pattern 4, it makes no difference, because you communicated that to the clinician where the patient is in the spectrum. Binary grading system is like recording the blood pressure, not in millimeter per mercury, as less than 140 or up to 140 and more than 140. So that more than 140 could be 141 or could be 181. But that is what you're doing, what we are doing with binary grading system. It is equivalent to that. So again, in this paper, we say in borderline cases, communication is critical. More grade categories is easier for the pathologists. Now, again, the argument, what about the clinicians? If I give them multiple tiers, well, they can decide how they want to break it up. So if they are more worried about whether they're worried about over-treatment or under-treatment, and we do that already with RCC grading, we give them a 4-tier system, right? Grade 1 to grade 4. And they would call 1 to 2 as low grade for the guidelines, 3 to 4 as high grade. They could say 1 to 3 is low grade and 4 is high grade, or 1 is low grade, 2 to 4 is high grade. That cutoff, depending on whether they are more worried about over-treating or under-treating, is something that the clinicians can decide. But the pathologists have to report. If you don't report the granular data, they can't manage. Thank you for your attention.
Thank you so much, Dr. Murli, for this very thought-provoking lecture. I now humbly request our director, our dean, and Dean Research, Dean Academics, to please kindly come forward for the felicitation ceremony. Dr. Radhika, please. May now request our Dean Research, Dean Academic, sorry, to deliver the vote of thanks.
Good afternoon. It is a great pleasure to thank all of you who could make it possible to attend this important oration on this very day. I thank deeply to our director, Professor B.K.Aikat, for his constant encouragements, positive attitudes, and always promoting the academic activities. Special hearty thanks to Dr. Murali Verma, a consultant histopathologist, who has traveled from such a long distance from UK to Chandigarh for this important oration. It is great, sir. See, you are in the limelight now, and I have to search you where you are. You could see your lecture. It is just a classroom teaching, perfectly befitting, and you can think, pin drop silence. Everybody was absorbed with the talk what we are giving. So thank you very much. A practical tips given such a beautiful way. It will go for a long time. Everybody will remember this oration as one of the best orations ever possible. So our deep appreciation for rendering the service. You look like alumni as you before. I had seen you just, you left, because I was 1 year in between when you were supposed to leave. So I can recollect the picture and everything at the same time. Thanks to our former deans, former heads of departments, professors, senior and junior faculty, and the guest audience. You are always a source of inspiration for us. You have been always pillar for the success of PGI. Whenever we see you, we are encouraged. We feel like working further and further. So we would always request and expect that your gesture and goodwill should prevail for PGI, for its growth and development. Thank you for being present here and gracing this occasion. Thanks to the family members of Professor B.K.Aikat, who could think that PGI should be the best place for this oration, for such a legend whose legacy is prevailing till today, and it will be prevailing for the years to come. The way he has developed the Department of Pathology, I could recollect that before joining PGI, he was there in Nagpur as well as in Kolkata, Gwalior, and every place wherever he was there, he established the Department of Pathology. See how beautifully he has started the legacy. Yeah, Calcutta also he was there. So this is the, you can say, for the vision of a person, you can say visionary. So such type of visionaries are very, very important for the growth and development of such iconic institutions. I should not forget to thank Dr. Nandita, Dr. Radhika, and all the staff faculty of the departments, I should say, for organizing such an important oration and with a full success. So thank you all for this. So I should thank to everybody from the bottom of my heart for being here and gracing this occasion. Thank you very much. Jai Hind.
Thank you, sir, and thank you everyone for joining us today. Now we'll, Nan Kishore tea, high tea is waiting for us down below. So please, please join us. That is also a legacy of this institute, honestly speaking.